Respected delegates, a very good morning to you all. Today I will be talking about precision in biometry, which is very much needed when we are going for premium IOLs. So, for perfecting our IOL power calculation, we need to keep on in mind a few things. Number one, that we need to prepare our ocular surface for biometry and cataract surgery. Secondly, is which machine we are using. And thirdly, what IOL formula we are using. So, for preparing our ocular surface, we need to know that the impact of ocular surface disorder will lead to error in measurement. Secondly, the patient won't be satisfied after surgery and might say that the surgery is the lead of the dry eye. And lastly, there is a risk of infection due to the ocular surface disorder. So what we do is we have to incorporate a dry eye workup in our cataract planning. This is very simple, will only take a few minutes more. What we do is when we see the patient in the slit lamp, we must see if the patient is suffering from any meibomian gland dysfunction, what is the status of the cornea, and we routinely are giving a dry eye questionnaire workup to our patients. Once we see that the patient is suffering from dry eye, we must go for treatment aggressively. This I'm taking the ASCRS protocol. Why treat aggressively? Because we have to reduce the surgery delay time. That is why the patient came here for cataract surgery. For treatment to reduce the inflammation, we can go for topical steroid and also oral antibiotic if required. And for treatment of the meibomian gland dysfunction, warm compression can be advised. So once treatment is done, we tell the patient to come back after 2 to 3 weeks. At that time, we again do all those tests, see the level of the dry eyes, and once we see that it has improved, we can go for biometry and cataract surgery. But one thing we have to keep in mind that we have to counsel the patient that apart from cataract, the patient is suffering from dry eye, and this treatment must continue after even surgery. Once we have done with the dry eye treatment, we move on to the machines. There are so many machines available in the market. The question comes, what machine should I use? Firstly, to start with, whichever machine is giving us a consistent good result, we can start with that machine. But to improve our biometry, we must move on to optical biometers. Why is that? Studies are showing that optical biometry is giving better accurate result in axial length. Why is this? It measures the optical axial length rather than the anatomical axial length. And it measures the axial length from the corneal epithelium to the Brooks membrane rather than only the internal limiting membrane, which is measured by the ultrasound biometry. And over here, light wave is used rather than sound wave by the ultrasound biometry, which has a shorter wavelength and is also more accurate. And fourth, this is non-contact. So obviously the patient compliance is much better, but most important than that, there is no chance of corneal indentation. So the axial length is more accurate. Also, we can have a measurement of the angle kappa here. Why is this important? We will talk later. And we also get a total keratometry by the newer biometry machines. So a few guidelines, whatever machines we are using, we must follow is that we have to ensure machine calibration. No eye drops can be given before keratometry. Why is this? Because our tear is part of our optical system. When we give eye drops, we change that. Also, our result of keratometry will be changed. And also, if it's any reading, K reading or axial length, if it's more or less than the average, we must do a recheck. Same, for this same reason, we have to do biometry of both eyes each and every time. Why? We need to compare and see if there is any discrepancy, and only then we can have a recheck. So these are the guidelines. Now let's move on to the IOL formula. I'll just be talking about one formula, that is the Barrett-IOL formula today. Why? Because again, I'm just showing you a study. This shows that the newer formula are giving more consistent result. And specifically why I'm talking about the Barrett-IOL formula. Yes, this is the formula that is available in the IOL Master 500 but 700. But more important than that, Suppose I don't have an IELMaster 700, will I not use Barrett? Yes, definitely we can use Barrett because this formula is available online free of cost in the ASCRS or APSCRS website. I'll just show that there are five formulas. The first is the Barrett Universal Formula, which can be used for all eyes of all axial length. Second is the Barrett toric calculator for correction of pre-existing corneal astigmatism with toric IOL. And the third one is very important, that is the Barrett True K formula for prior refractive surgery patient. This is used. And only last year, Dr. Barrett has improved this formula by making it the Barrett True K TK formula. Now the total keratometry is being used here. So this formula can now be used for biometry of keratoconus eyes even. So this is very important. The fourth formula is the Barrett True K toric calculator for prior refractive surgery eyes with corneal astigmatism. And the fifth formula, Barrett RX formula, can be used for IOL exchange or piggyback IOLs. Now, since we are talking about premium IOLs, I'll talk a bit about biometry for toric IOL. So, when do we know that the patient requires toric IOL? Is by seeing the preoperative corneal astigmatism. So, what is that? That is obviously we know is the difference between the K1 and K2. If this is one or more, this patient is definitely a candidate for toric if the astigmatism is regular, that is the steep and flat meridian are 90-degree apart. We will just see an example. This is a biometry. We can see that the K1 K2 difference is 1.1 and the astigmatism, the difference between the two axes is 90-degree apart. So definitely I will think that yes, this patient I can go for toric IOL. But one thing we have to keep in mind that total corneal astigmatism is now the summation of both the anterior and posterior corneal astigmatism. But that K1, K2 difference, that was just the anterior astigmatism. So where do we get the posterior corneal astigmatism for? Why do we need it? Because studies are showing that when we include the posterior corneal astigmatism in our measurement, the toric IOL calculation becomes much more accurate. And again, Dr. Barrett has made our life easier because in the Barrett toric calculator online, already the posterior corneal astigmatism is been included, as we can see here. So what we do is we just put in our data and we get the IOL power needed, the model of the IOL, and lastly, as we can see that the axis of placement for this patient is 90-degree. Let's move on to presbyopia correcting IOL. The main problem with this patient that they face halos and glare. Like for some patient, as we can, the patient can see clearly at night, no problem. But for some patient, we can see that the halos are glare, like the fourth picture is so much the patient cannot do any work. And they are like, what lens have you put in me? So can biometry help us in suspecting that which patient can have halos and glare? Yes, it can. For that, what we need to understand is the angle kappa. Angle kappa is, if we think, is the angular distance between the pupillary axis and the visual axis. So if we see here, this is there in the eye, there is a yellow dot and the blue dot. The distance between this is the angle kappa. If the angle is small, that is the distance between the blue and yellow is small, the patient usually don't suffer from halos and glare and is a good candidate. But as we see in this eye that the yellow and the blue dot are far apart in the second eye, so this patient has a more chance of suffering from halos and glare. Why? Because when the light travels, it might hit the diffractive rings. This is where the halos and glare comes from. How do we know that where is the angle kappa more or less? Again, our optical biometry is here to help us. In IELMaster 700, there is a measurement included. This is the chord. So what we will do is we will just ignore the signs. I'll just make it simple. So the summation of these two values, that is the px and py value, we just need to keep this in mind. If the summation of these values are more than 0.6, this patient will suffer from halos and glare and we should avoid multifocal IOL in these cases. And lastly, before ending, I'll say that by incorporating dry eye workup in our practice, by using more than one machine, and one of them should be optical biometers, and by using the latest formula, we will have more perfection in our biometry. We will be able to provide the targeted refraction for the patient. The patient will be happy, and obviously the surgeon will be satisfied. Thank you for your hearing.